Hello and welcome to GBMC's Greater Living Live. I'm Mary Beth Marsden. Today we are talking about something that is so important to our overall well-being, and we often don't think about it until there's a problem. Joining us now is Dr. Tanvi Shah, who is a comprehensive ophthalmologist and cataract surgeon at the Eye Center at GBMC. And obviously we'll be talking about your eyes, issues with your eyes, specifically cataracts and glaucoma. Dr. Shah, thank you so much for joining us.
Absolutely. Thank you for having me.
I have to say, I am one of those people who definitely is late for getting an eye exam, and I kick myself when I think about it, but it's not top of mind because I'm not experiencing any issues, and I'm probably like so many others, right?
Yeah, and especially with the recent COVID and current COVID, it's been definitely a delayed exam. Yeah.
So why is it so important to really kind of keep up with our eye exams?
So as I tell my patients, a lot of times you won't have signs or symptoms if there's something going on with your eyes. So meaning early cataracts, early glaucoma, early macular degeneration, diabetic retinopathy, many of it doesn't have signs or symptoms that you'll pick up on at home.
So when you say routine eye care, what does that mean, and what does that mean depending on your age?
So for my practice, a routine eye care means coming in, getting your vision checked, checking for glasses if patients are interested or need them, checking your eye pressure, and then doing a dilated exam to look inside the eye to examine the retina, the optic nerve, looking for cataracts, etc. Just doing a full, complete exam. A lot of patients don't want to be dilated, and that is I tell my patients they're getting an incomplete exam. They're missing a
Yeah.
big critical part of it.
Is the dilation the same as it has always been, or is it a little bit less long lasting?
So the dilation is the same as it's always been since I've been practicing and as a resident. It's, a couple eye drops. They last about, I say 4 to 5 hours. In reality, you get adjusted to it pretty quickly, maybe 1 to 2 hours. I tell most patients if they feel comfortable, they can drive home. They will be sensitive to the light. Our office does offer some disposable shades for you to be more comfortable driving home. And it really affects you mostly for near work. So patients that, are trying to be on the computer all day, if they're naturally nearsighted, they can take their glasses off. But reading your cell phone, texting, things like that will be difficult, but distance vision generally is unaffected.
So should we be doing this once a year?
They say over the age of 40 once a year to start, and then depending on what that exam shows, it could be every year, it could be every 2, it might need to be more frequently for just, depending on the eye health at the time.
And it's funny because at the beginning of this conversation, you mentioned COVID, and I was thinking, wow, that's certainly something that got put on the back burner for maybe 2 years for a lot of people, if not more. What did you see? Did you see a rush of people when everything freed up a little bit, or are people just now getting back into the groove?
We're still seeing a rush of people. So unlike many of the other subspecialties, telemedicine does not work for adult ophthalmology. You cannot easily refract a patient to see which is better, 1 or 2, to get them a new prescription. Many of my patients are older, and asking them to even just check their own vision and put a piece of paper that we pre-printed and sent to them 20 feet away to check their vision wasn't feasible. Doing an eye exam through Skype, Zoom, FaceTime doesn't really work. You don't have
Right.
the microscope.
Right. I hate to scare people, but a great way of getting people to sort of commit to their exams is to give them anecdotes about what can happen if you don't, and what are some of the downsides of not keeping up with your eye care, or potential downsides.
So as a cataract surgeon, I do see right now a lot of patients that are almost legally blind, not safe to drive from reversible cause of blindness, cataracts. Cataracts are fully treatable, and if you have loss of vision from cataracts, we can restore that vision, but they may be not realizing how poorly they're seeing. Patients with glaucoma that haven't had pressure checks could be having increased pressure. They won't feel it, they won't notice it, and they could have loss of some peripheral vision. Diabetics with diabetic retinopathy may not notice it and could have, better control of their sugars. If they knew that they had some damage, they might be more motivated or interested in bringing down their A1Cs and controlling their blood sugars better. Same thing with the macular degeneration patients. The treatments are injections for wet macular degeneration. They're done very frequently, but the sooner we get started on them, the sooner they will have resolution or control or less progression, hopefully, of their macular degeneration.
And am I correct in saying that if a patient comes to you, you can readily diagnose cataracts, macular degeneration, glaucoma? Those things are pretty quick for you to see, right?
Correct. So with the caveat of the full dilated exam. So now if you don't want to be dilated, you've got a portion of the exam, we cannot diagnose all of that and manage it without a full dilated exam.
Okay, we've heard the term cataracts. Anyone who has grandparents or are of a certain age, has friends maybe dealing with it. What is a cataract?
So I joke, but truthfully, I tell patients that cataract is the gray hair or wrinkle of my world. Every single patient with age should develop a cataract. You can develop a cataract younger for other reasons, but the general rule is the lens in your eye that you're born with gets stiff with age and then it gets cloudy. And we encourage cataract surgery, or at least I do, when patients feel that they don't see well, to do the activities they enjoy doing, even with a new pair of glasses.
And do cataracts usually mean a slow change in your vision so that you might not notice it for a while?
Correct. And that's part of the problem, is that it's a very, very slow progression. So you kind of just adjust or accommodate, right? Oh, I use that brighter light. Oh, I don't really, larger print books or something. But sometimes it's so subtle that you don't even notice that you're not seeing as sharp as you used to, because it's very, very gradual onset.
And besides it potentially being unsafe by altering your vision or decreasing your vision, is there a downside to not having it treated earlier rather than later?
So both ways work. I tell patients if it's not visually significant and not affecting their quality of life, I don't like to say activities of daily living, I like to use quality of life, then you may not be impressed with the cataract surgery. You may be outweighing the risks to benefits. However, if you wait too long, you may not be legal to drive, or if the cataract is very dense, it may take more energy, higher risk of complication, slower recovery if the cataract is too far dense. Also, some of the patients are really, really limited on their vision. They cannot see the TV even. So quality of life is a big one there.
What's the downside of surgery?
It's a real surgery, so you're going to need to be, what we say NPO, nothing to eat after midnight. You're going to get some IV sedation. You need a history and physical. You got to lay flat on your back. Surgery takes about 15 to 20 minutes, but we're making an incision. We're removing the lens in the eye, replacing it with a man-made lens, an intraocular lens implant. So there's always a risk of infection. And with any surgeries on the eyes, we always say loss of vision, retinal detachment, glaucoma. They're very, very small risks, but all the risks of surgery still exist.
So if I come in to see you, Dr. Shaw, and you see that I have maybe, I don't know if you call it a small cataract or a thin cataract, and you say to me, you give it a level, maybe a percentage-wise, do I keep coming back to see if it's getting worse? Does it sometimes just stay stable?
So I tend not to give patients a level because, again, I believe more on the patient's quality of life. So sometimes I'll feel a cataract is mild, but the patients are miserable in whatever they enjoy doing. And to them, it's worth the risk-benefit ratio. Other patients, I will push surgery because they're driving, but their vision is borderline. And I'm like, if you want to continue driving, it's really time to do surgery. So I really leave it up to the patient. I do watch them every year. So if someone, to me, looks to have visually significant cataracts, but is not bothered by their quality of life, and they're still seeing well, I will see them every year to make sure that their vision isn't declining to the level where they're not safe to drive. If they're no longer driving, then I'm a little bit more flexible, but we still want to make sure that the cataract doesn't get to the level where it's going to be very, very difficult for the patient to remove or a higher risk for a complication.
And speaking of complications, what are the risks?
Any eye surgery risks. So we always say the worst case scenarios with the eyeball: loss of vision, retinal detachment, glaucoma. Some patients want cataract surgery to be glasses free. So there's always a risk that you're going to still need glasses full time after the surgery. Chance a piece of cataract's left behind, need to do second surgeries, swelling, edema, pain, as any surgery. Very minimal risk with cataract surgery because you are awake, so there really isn't a chance for pain. But everything we always talk about with anything.
So are you saying that pretty much everyone, once they get to be a certain age, at some point in their life, will develop a cataract? Is that accurate?
Absolutely. Correct.
In one
Absolutely.
eye, both eyes?
So generally speaking, if they're age-related cataracts, they will be symmetric and in both eyes. However, if someone's had trauma or surgery or a medication risk, sometimes it'll be in only one eye more so than the other eye.
Surgery, would that include LASIK?
Not LASIK, because LASIK's done on the front surface of the eye, but intraocular surgery, so a glaucoma surgery, a retinal surgery, even a laser procedure sometimes can increase the risk of cataract formation.
Okay, so what if you're a person who does have cataracts in both eyes? Can you get both done at once? I would think that would be difficult.
You can. I do not offer bilateral simultaneous cataract surgery. I generally say the risk-benefit ratio isn't worth it. It's better to do them 2 weeks apart. So I do one eye first. I see the patients, make sure they're healed, happy, seeing well before I do the second eye. Or if there's a complication and they need a little bit longer to recover, they still have the unoperated eye to help them.
Okay, you did mention too, and I want to touch on this because it affects a lot of people, the role of
Yeah.
diabetes and your eyesight, and how it's a little bit different to have a diabetic eye exam. Can you talk about that a little bit?
So a diabetic eye exam is looking for diabetic retinopathy. With a dilated exam, we're looking for cataracts also because diabetics with their sugar fluctuations tend to develop cataracts earlier. I consider a diabetic eye exam part of the routine eye exam. So in every patient that I dilate, I do look for diabetic retinopathy. You'd be surprised. Sometimes you can diagnose diabetes on the retinal exam prior to them having the clinical diagnosis of diabetes. If they haven't seen a primary care doctor or been checked, you can sometimes see changes in the eye before the patients know about it.
So you mean someone's changes in their eyesight could be a sign of diabetes, like they weren't even on that wasn't even on their radar yet until you saw them?
Correct, especially if a patient doesn't have routine medical care. Someone's not checking their sugars and someone's not checking their A1C levels and making sure they're not developing diabetes. So when you do get first diagnosed with diabetes, if you haven't been getting regular care, we don't know how long your sugars have been running high for. So they recommend an eye exam close to the initial diagnosis of diabetes in adults.
And you said that sometimes a person with diabetes will develop a cataract earlier than a person who does not have diabetes. Can you develop, once you have that removed, let's say, can you develop another one right after it?
So once a cataract is removed, it is removed. You do not develop a second cataract, no matter if you're a diabetic or anybody else, routine cataract surgery. So once a cataract's taken out, it does not come back.
I think I'm going to switch gears a little bit to glaucoma. That I think a lot more people are afraid of developing because of what they've heard. And they've heard that there's a difference in the dry kind and the wet kind, but I don't think people really understand what that means.
So glaucoma does not come in dry or wet. That's macular degeneration.
Oh, macular degeneration. That's right.
Yeah.
So let's start with glaucoma.
Sure. So glaucoma is pressure in the eye that goes up without the patient usually realizing it. There's two types of glaucoma. The more common type of glaucoma that we consider, or patients consider glaucoma, is what we call open angle glaucoma. No signs or symptoms early on, which is again why coming in, getting your eye pressure checked in the dilated exam is important. There are about, I want to say close to 50% is the data, I think, of patients that have normal pressures but still have evidence of glaucoma damage on a dilated exam, which is why I kind of keep harping on this dilated exam because nobody wants to be dilated. It's not fun. They're light sensitive, they're blurred. But to me, if your pressure is normal, that doesn't tell me enough. I need to look at that optic nerve to make sure it doesn't look like there's any evidence of glaucoma damage, even if the pressures are normal.
I would imagine that every single patient you see asks you at some point, do I have to be dilated? Does everyone say that?
Almost everybody says
Yes,
that.
I
There's a
thought.
rare patient that's like, oh, I don't mind. If you want to do it, go ahead, and then on top of it, if they have a subspecialist that they follow that, I saw the optometrist, they dilated me. Do you need to look again? Well, they're not going to be doing what I'm doing, or they sent you to me for a reason. I kind of need to make my own decision as to where we need to go forward with it.
Right, right. And this is so different, glaucoma, from cataracts. I mean, cataracts is something you kind of talk about the quality of life and whether they need to treat it, but glaucoma, you've got to get on it, right?
Correct. So glaucoma causes irreversible loss of blindness without treatment. You cannot bring the vision that you've lost from glaucoma back. So the goal of glaucoma treatment is to lower the pressure to the acceptable range to prevent further damage. Now here's the catch on that one. We don't know what the acceptable range is. It is individualized to every single patient. So just because your pressure is reading one pressure and the other patient's pressure is reading higher or lower, it doesn't mean that's accurate. So you've got to follow up and make sure your that pressure that you're at doesn't cause any further damage.
So you need to get a baseline, is what you're saying,
Correct.
for the individual.
Correct.
And then watch to see what it does. Is all glaucoma, even if, okay, so if there's been damage done, there's nothing you can do, but you can stop glaucoma in its tracks, or you can slow it? Where are we with that?
So we cannot stop glaucoma in its tracks. I mean, that's the goal, right? But we don't know what the pressure is for each individual person. So we have to adjust accordingly, meaning we want the pressure where you don't develop damage. So we watch you, and if we think we see progression, we treat further.
So what are some of the treatments for glaucoma?
So I am not a glaucoma specialist, but generally speaking, first-line treatments are eye drops because they're better tolerated by patients. If for some reason a patient cannot tolerate eye drops, and there's multiple classes and multiple medications within each class, kind of like blood pressure medications. If you cannot tolerate it, we kind of switch around and figure out what works. However, there's also laser treatments for glaucoma, minimally invasive glaucoma surgery, and then more invasive glaucoma surgery. And when patients get to the laser, minimally invasive, or surgical glaucoma procedures, I tend to refer to the glaucoma specialist. However, first-line therapy is eye drops. Some of them are just once a day. Some are twice a day. You can take multiple medications if needed. And then if you still feel, or the physician feels that the pressures are not controlled, there's still progression, doing a laser and eye drops are even an option, or surgery and eye drops.
So, and why would the drops not work for some people, and you would have to refer them onward to a specialist and possibly to surgery?
$1 million question. Why does it not work? We don't know. We don't understand glaucoma enough to know why certain medications work better in certain patients, why certain medications don't work, or why medications stop working. So we see glaucoma patients quite frequently in the office, about every 3 to 4 months, 3 to 4 times a year, to make sure the pressures are controlled, the medications are still working. Because unfortunately, the patient can't check at home like a blood pressure cuff, and they can't feel the changes, just like blood pressure. You don't know if your pressures are high.
So you're the frontline screening for obviously cataracts, glaucoma, and macular degeneration, right?
Yeah.
What I know it's not your specialty, but what is macular degeneration?
So just to go back a little bit, I call myself the internal medicine of ophthalmology, right? A comprehensive ophthalmologist. And then if you need to see the cardiologist or the pulmonologist or anybody else, that's where the subspecialties come in.
Got it.
The subspecialties love to just do subspecialty work. They do not want to do cross work, right? You're not going to ask your cardiologist about your lungs. It's not going to work.
Yep, totally get it.
And then the follow-up.
Well, I was just wondering, but you still will see the macular degeneration in an eye exam. And this would also involve being dilated.
Correct. So macular degeneration is age-related changes in the retina that we see in some patients. Again, $1 million question. Why some? Why not others? We don't know. It's something we can pick up easily on a dilated exam. We also have additional testing that we do if we see any changes consistent with macular degeneration to determine if it's wet or dry. Dry macular degeneration these days, there are some study trials out there that the retina specialists will do, so we do refer to retina still. However, the mainstay of treatment for dry macular degeneration is green leafy vegetables, lutein, eye vitamins, and monitoring to make sure it doesn't convert to wet macular degeneration. Wet macular degeneration, we do always refer to the retina specialist because it's best managed with injections in the eye.
Do you think, in your opinion, are we getting the word out to the general public about how important it is to really keep up with your eye health?
I think it's tough. I think with COVID and masking and in the eye exam, you're what, a foot and a half away from each other under the microscope. And the elderly population that these diseases present in, generally speaking, are reluctant with COVID and that way things are right now. And then you take the winter months, snow threats. You know, people don't want to come in during rain and snow. So that's not easy for them.
Well, hopefully there's some people watching and listening right now, and they're thinking, I need to get on that, and I'm one of those people. So if I am one of those people and I need to have I think sometimes you can go and get an eye exam and it's not thorough. Would you agree?
Absolutely. I think a
Yeah.
lot of places nowadays offer undilated fundus photography. And in my opinion, as an ophthalmologist, I think if you can be dilated and tolerate it, you get a much more broader view, a much more detailed view, and a much more interactive exam where the examiner is able to see more, I guess I want to say, or better than a
Yeah.
camera can.
So how would people go about getting started? Really getting a good eye exam with you, let's say.
I would just suggest they call the GBMC Eye Center. We have 2 locations. I'm at the Eye Center at GBMC, and we also have an Eye Center at Joppa Road, and we have ophthalmology and optometry in both locations. And we'd be happy to see anybody that can call us and wants to come in.
Anything cool, new, and exciting on the forefront that you can't wait to see put into practice as far as eye health and eye care goes?
There's a lot always coming out in terms of helping macular degeneration patients. New technology in cataract lens implants is always my favorite. Too much to discuss all in one visit, but there are lots of options out there for patients.
All right, that'll be our next interview, okay?
Sounds good.
All right. Dr. Tanvi Shah, thank you so much for joining us and talking about the great work being done at the Eye Center at GBMC and your work as an ophthalmologist and detecting cataracts and glaucoma and so forth. And we appreciate you joining us on Greater Living.
Thank you. Have a great day.